everybody, and welcome to yet another edition of the Slumber Party podcast. I am your host, Amanda Jewson. My lovely partner in crime, Lisa Ramrine, is stuck at home with 3 sick children. And we send our love and we send our support and we send our healthy vibes to you, Lisa. Don't go crazy, but if you do go crazy, it's perfectly understandable and it's okay. Today this is a culmination. I manifested this. I have been looking for 3 years to speak with a doctor about my experience personally with sleep apnea. And I'm so excited to welcome Dr. Anya McLaren to the podcast. And I say I manifested it because, Anya, you came to me. You found me. I was literally I'll never forget it. I get a text on my WhatsApp. I'm making lunches, the bane of my existence. And you're like, hey, I'm a pediatric sleep respirologist. Do you want to talk about things sleep? I was like, yes, I do. And then we had like an amazing conversation that we had to shut down because we both have lives. So thank you so much for coming.
Oh my gosh, I'm so really excited, and it's such an honor to chat with you. We did connect when I randomly I actually Googled, you came up, and I we had a wonderful conversation, which was so exciting. But yeah, no, I'm glad that we were able to connect, and I'm glad we're able to share this space to have a conversation about sleep apnea in children.
Totally. Well, tell us a little bit about what you do. So I kind of want to give a context to the folks at home. Where do you come into? What do you see? What's the sort of practice that you do with kiddos?
Sure. So as you introduced me, I'm a respirologist and sleep medicine physician. So in terms of my background, I went to medical school. I trained in pediatric medicine and then subspecialized in pediatric respirology, which is basically everything related to the lungs and breathing, and then did an additional year-long training in sleep disordered breathing, or actually in pediatric sleep medicine. So that encompasses sleep disorders related to breathing issues, but everything else. And so currently my practice is a mix of any child who has breathing related issues when they're awake, so asthma, any chronic lung disease, but of course when they're asleep as well, so sleep apnea, and any spectrum of disordered breathing that occurs during sleep. And so the kids that I see are kids that are otherwise healthy who have sleep-related issues. And sleep apnea can actually present in a number of different ways, which I'm sure we'll get into. And so I see kids ranging from newborns all the way through to 18 years of age.
Interesting.
With any sleep-related issue and any lung-related issue.
Okay. So while you were saying that, I was wondering, so would a patient be referred to you if there were sleep issues and the parent actually had no idea what was going on?
Yeah, I see any and everything. So we get referrals from primarily primary care providers, so pediatricians, family doctors, nurse practitioners, who have patients that have sleep complaints. So that has ranged from, kids not being able to fall asleep at night, to kids waking up frequently at night, to kids having behavioral issues in the daytime, to kids snoring. Yeah, so it's a very broad spectrum.
Okay. Oh my gosh. Oh, I'm so excited to talk to you. Honestly, I'm so excited to talk to you. This is like such honest and genuine enthusiasm. Like I'm actually getting emotional because this is like a full circle moment for me, because and everyone on this podcast listening, when we are working with clients, 99.9% of our clients were dealing with a behavioral issue that a child requires to sleep. And we remove the behavioral issue, with lots of love and care, and then they sleep well. But there are that 0.1% where we get to the end of the road and we say, you know what? I don't know why, because this works for so many folks in so many ways. It for babies, for kids, this is a thing that's working. And often what happens is we say that to the parent and we say, look, this is the end of our expertise, and we are not doctors. We're not going to pretend to be one, and we don't play them on TV even. So I can't even use good words to pretend that I'm a doctor. And then the client of ours will go to the doctor, and the doctor says, well, babies just don't sleep. Kids don't sleep. That's a thing. They just don't sleep.
Yeah,
And
yeah,
then there's nothing for the parent. And in my experience, I'm sorry, all our clients do sleep. So I just
right,
don't buy it when you've
right.
done so much. And when you've looked at all the behavior and overall the child, to your point, otherwise healthy, that's such a key word.
Yes.
There's nothing, they're not screaming anything, and I know this from personal experience, right? Like
Mhm,
on the
mhm.
surface or on the outside, it like looks a certain way. So I I am dying to know, w- a two-part question. What are some of the things that could be impacting the child's sleep or a baby's sleep that may not be obvious to an otherwise healthy child? That's question number one. Two, how the hell do we see you? Can you come? Do you do
Yeah.
clinics?
Yeah, so I mean, I guess in terms of the first point, so sleep apnea, for example, which is a condition where there is impairment or and you know where babies or children, and it can actually happen in babies, have limitations in their breathing such that they're not able to get the air in and the air out when they're asleep.
Yeah.
And the reason that we see sleep apnea happen, at night compared to during the daytime is that when kids go to sleep, they rely completely on their built-in sleep regulation by the brain. When we're awake, we have lots of conscious and wakeful drive to breathe that can, supersede any limitations that could
Mm.
potentially be there. So, in terms of sleep apnea, for example, it can present with kids who snore. That's typically sort of a big red flag. So, snoring in a child is just not normal. And so, um, apart from snoring, because what I've noticed is that the older the child gets, and once they're in their own room, if parents are not checking in on them overnight or don't have monitors in the room, they may not clue into some of the signs or symptoms of sleep apnea. So,
Yeah.
sometimes it can be a light snore even. It doesn't have to be a really loud snore, but kids who are restless in their sleep, kids who sweat in their sleep. I know that, you probably see a lot of the younger kids, but older kids who, for example, stop wetting the bed and then start wetting the bed again. Um,
Yeah.
yeah,
Sorry.
yeah.
I told myself I would shut up and wait my turn. So go ahead.
Yeah, so kids who grind their teeth, for example, that can also be a sign that they're having breathing limitation during sleep. Kids who wake up from sleep tired and not they don't seem refreshed. Like if a child is asleep for 10 to 12 hours, in the morning, that child should look refreshed, energized, ready to face the day. So kids who are grumpy or irritable and just don't look like they've actually slept really well. And then, of course, there are daytime behavioral issues of, mood, lability or irritability, issues with attention and focus, issues with being impulsive and aggressive. Um, that can be a way that not only sleep apnea, but any poor quality sleep that a child gets overnight, that can be a way that it would manifest in the daytime. Kids who have issues with actual pauses in their breathing. So sometimes what that might look like is a child who snores, 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 stops breathing, big gasp, breathes normally for a bit, then snores, 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 and continues to do that throughout the night.
And would you so that's I mean, I really wanna talk about sleep apnea, but are there any other health conditions that might come up that
So
aren't sleep
many.
apnea? Yeah.
Yeah, so we know. So I mean, I could talk about this a little bit later, but I'm in the process of creating a course that I hope will help sleep consultants in particular to have an idea about what different types of sleep issues could be that might present like behavioral type issues, because that
Yeah.
that oftentimes can be the case. But children who have asthma, for example. So, asthma is when there's inflammation of the lower airways that typically presents with wheezing and coughing. It tends to actually be worse overnight. So, a child who's coughing
Mm,
overnight, that could be related to asthma. It could also be related to sleep apnea, because you can get
mhm.
coughing, gagging, choking related to breathing limitation. But asthma is one big one. Kids with allergic, what we call allergic rhinitis or allergies. So
Mm,
seasonal type allergies, or allergies related to dust, for example, with sneezing,
mhm.
itchy eyes, and itchy nose can disrupt sleep. There's also eczema as well. So kids who itch significantly during sleep. Reflux is also a big one. That can
Oh,
be
yeah.
quite disruptive to sleep as well. And
Yeah,
so, of course, any child with any chronic disease, so kids with cystic fibrosis or sickle cell disease, can have sleep disruptions. But for otherwise normal, healthy kids who don't have like a chronic condition, I would say reflux, eczema, asthma, and um, yeah, I think eczema as well. Those would be some of the conditions to think of. And then outside of that,
yeah.
there are actual sleep disorders. So, restless leg syndrome, for example, which is basically when kids have this internal sense of discomfort in their legs. And those kids might actually look like kids who are resisting bedtime because they're very hyper at night because of that internal. When in kids with restless leg syndrome, they're wanting to move is more pronounced when they're required to be still. So
Yep.
at night when they're lying still in bed, it is this discomfort, and that only improves when they move their legs. So
Right.
the way that I sometimes will ask patients about it who are old enough, I'll ask them, imagine that you were able to lie still in the bed. Do you think that's something you could do? Oftentimes, I actually had a patient with this yesterday. Oftentimes they'll respond, no, I just feel like I always have to move. And then I'll ask specifically, is there a certain part of your body that feels especially uncomfortable? And then I'll throw out, is it your head, your arms, your legs? And then they'll say it's my legs for sure. So restless leg syndrome, and then when you're actually asleep at night, periodic limb movements. So those are basically very small movements of the legs that occur periodically throughout the night and disrupt sleep quality.
Mm.
Um, there are also movement-related sleep issues as well. There's teeth grinding. So there are quite a few
Yeah.
sort of sleep disorders, yeah, for sure, outside of like sleep apnea, for sure.
The top ones that I've seen as well in my practice when I always kind of follow through with the client if we haven't reached our goals for whatever reason. So, like I said, we stay until you're sleeping, either with us or someone else. There are quite a few, especially in babies, gastrointestinal issues or food allergies,
Right.
reflux. Those seem to be the big ones that come out.
Mm-hmm.
Reflux, especially like babies that just can't settle when the food is there and the behavior is there and they just can't settle. We have to consider that they might be uncomfortable for some reason, and that always
Yeah.
requires investigation. The other
Yeah.
thing that I've seen lately with older children as well is low iron
Oh, yeah.
impacting the quality of sleep for like my preschoolers mostly. And we
Yes.
see this, I think, once we move off from formula and into or like breast milk or any sort of we forget to fortify, right? You give babies the iron drops or the, the whatever they are. I'm thinking vitamin D. But Anyway, we're supposed to supplement with iron, and, um, as kids get older and pickier, they eat less variety of foods, and we see iron drop, and that has actually been quite revealing, and that's been something that I've seen over the last 2 years, especially because I think doctors are kind of getting wiser to that, and that is something that you can do with your family doctor, like a quick blood
Yeah,
test
yeah,
and have that
yeah,
evaluated without having to
yeah.
see you.
The interesting thing about low iron, so low iron is one of the causes of restless body movements during sleep, restless leg syndrome, and
Right.
periodic limb movement disorder. The interesting thing, though, is that the iron level that has been associated with that restless movement is actually can actually be within the normal range.
Interesting.
So sometimes if kids are having, or fit the criteria for a restless leg syndrome condition, for example, they would have to. I mean, you check the iron level, but you want to get them a bit higher
Mhm.
than what the normal range is. And the periodic limb movements disorder, however, you'd have to get a sleep study in order to diagnose that one.
Right.
So
Yeah.
yeah, but for sure, I mean, just recently there has been a new condition termed restless body movement during sleep, which is something again that you pick up on a sleep study. It's similar. It sort of is in the spectrum of restless leg syndrome and periodic limb movement disorder as well. So, um, yeah, I mean, the iron is definitely something. I agree in the
Yeah.
preschoolers and sort of that age where they, the picky eaters who come
Yeah.
off of the formula which has iron in it, and are not great meat or green leafy vegetable type kids.
Yeah.
It is something that we see for sure.
Yeah. And I mean, I just wanna I mean, I e anytime it's part of our intake analysis when we're working with our clients, especially our toddlers, is
Yeah.
we always ask, "Is there snoring? Is there any sort of breathing
Hmm.
issue?
Hmm.
Does your child sleep with their mouth open?" And
Hmm.
generally, I mean, we always say we can help with the behavior part, but if
Right.
there is anything that's impacting your child's breathing, they're going to wake. And this
Hmm.
was something that I mean, I had a journey with my daughter's sleep apnea, and I'm just so blessed and thankful that I had this sleep education behind me. And
Hmm.
even just this kind of heads up, like, "Hey, kids are having apnea and this is what it looks like." And I was like, "Oh, okay. I'm glad to know that." And then my first daughter was just such an amazing, miraculous sleeper as a baby, just slept like a champ. And as we got into the 3, 4, 5 zone, I just felt like, number 1, if she had a cold or any sort of respiratory illness, she really got it. She always had ear infections. This was me as
Hmm.
a child as well. I had my
Hmm.
tonsils and adenoids removed. I had tubes put in my ears. I had ear infections for literally years of my whole life before the surgery. And I sort of, so that put me on guard already. And
Yeah.
then, we noticed, especially when she was sick, she would snore like a 87-year-old smoking man. Like, my husband would send me it was, like, kind of funny, like, she would be upright in the car seat sleeping, and so we thought maybe it was a sleep position, but then it started to become something we could hear in the hallway at night, and
Hmm.
then she was I mean, this is still who she is, but she was a chronic early riser. So she
Hmm.
would be up, and I understand why now. So in the second half of your sleep, you're in mostly REM for the second half of the night. You are in lighter stages of sleep. If there's anything waking you, you're going to be more conscious than at any point. But we're talking about wakings into the like fours and not being able to go back to sleep, like
Yeah.
constantly waking herself up. Um, so when she was about 4 years old, I requested an ENT, and the person that saw me told me that snoring is normal in children, and that I am not exaggerating, I do exaggerate, shocking, but I'm not exaggerating when I say he took the tongue depressor and went, "Yeah." she's fine. Like, that was the level of analysis. I was so mad for many reasons, but I left the clinic and I called my doctor and I was just like, I'm not saying that he's not wrong, but I just want a second person to actually look in her mouth because I
Right.
don't feel like he did. So we moved to a different ENT, and that ENT was wonderful, and they really took the time to listen to us. The ENT actually, the first one was a pediatric ENT. The second was an adult, but he took
Mm,
all the time and care with me, which I loved. So he said, "Look, you know what? We see a lot of fluid on the ears. We can try these nose spray for a little while to see if that helps, and we can maybe avoid surgery." So we tried that. No real help. Nothing moved the needle. So we were referred for a sleep study. And by the way, this is like pre-COVID. I don't know what the wait times. This is all within now a year. So we've
well,
waited a year. So now,
yeah.
when he is 5, and now we have to wait for a sleep study, which is another, like, I think 6 months we waited for
Yeah.
the sleep
Yeah.
study.
Yeah. Yeah.
And I'm happy, like, yay, public health care. But anyway, we waited a long time. We finally got the sleep study. I mean, I do believe in public health care. I'm a big advocate, but I don't want it to come off like I'm complaining. That's just what happens sometimes.
Mhm,
So
mhm.
my husband had done a sleep study previously. I knew that it was going to be pretty invasive, and I was like, I don't think I can go. So you go, he goes. She was up like every hour on the hour. And I
Mhm,
mean, yes,
mhm,
you're in a new space, which probably didn't help. Long story short, she was diagnosed with mild to moderate apnea.
mhm.
She stopped breathing for, I think, and by the way, I feel like, and correct me if I'm wrong, the diagnosis for even mild apnea is that you stop breathing for 10 seconds at a time. Is that right? Or
It
is that different?
depends. So it
Okay.
depends. Yeah, so mild obstructive sleep apnea, basically the criteria that we use is having 2 to 5 respiratory events per hour. So that
Right.
can include actual pauses in breathing or shallow breathing that leads to drops in oxygen saturation or to a mini awakening or arousal. So
Got it.
the number of events per hour is a combination of actual pauses as well as shallow breathing.
Got it. Okay.
Mhm.
So, I mean, even that for me, like, even just hearing that 2 to 5 per hour is wild. So, anyway, she was diagnosed, thank goodness. And then it was like, well, what do you want to do about it? The situation was put on us. So we spoke with our doctor. We were referred to a surgeon. And by the time that, like, when we got to the surgeon was very dismissive before he looked at her. And he was like, like, not everyone needs their tonsils out and blah, blah, blah. I was like, I don't want this surgery. So, like, if you're going to tell me that this is something that we don't have to do, I'm going to be thrilled. He took one look in her ears and then said, "What took you so long to get here?" And I was like,
Mhm.
I have been pushing and pushing, and every single doctor along the way has essentially told me that I'm hysterical. They moved
Mhm.
up her surgery. So we thought her surgery was going to be in the new year. Thank God, by the way, because the pandemic happened right after.
Right, right.
But they moved it from like January, February, right up to like November. Like,
Wow.
yeah. So they moved her up really quickly. The doctor came out, they removed her tonsils, adenoids, they drained her ears. He said he had never seen ears like that in
Wow.
all. Like, she was at a point where the volume on the television needed to be so
Yeah.
loud,
Wow. I remember you
and
telling me, yeah.
it was so crazy. And I feel
Mhm.
like I trust medical professionals. I'm very medical
Mhm.
friendly. I believe in science, and I don't know how. uh, I'm glad that I persisted, but there were
Mhm.
several pieces of advice along the way that told me not to. I can
Yeah.
tell you the day after her surgery, this is the night of, we co-slept because there's a complication with the surgery that you
Yes.
want to be I don't want to scare anyone, but there's a very rare but serious complication that I just wanted to monitor. So we co-slept. She didn't snore. This is like day of surgery.
Yes.
She
Yes.
was breathing beautifully. I It changed her entire disposition,
Yeah.
her behavior in school changed. We had friends comment, be like, "She's just a different girl." I'm like, "I
Mhm.
know, because she's
Mhm.
rested." And I just, like, so I'm very conscious of, like, the clients that I can't help. You go to the doctor and the doctor is telling you it's fine. Like, what do
Yeah.
you do? How do you persist?
I know. I mean, I think there are, so, I actually, you know, have actually, so in the process of creating this course that I had mentioned earlier for sleep consultants, I, of course, have done background, research looking into, just sleep education
Mhm.
in
Mhm.
general,
Mhm.
I mean, and actually, like every resident, so I work at a tertiary care center, so I teach future doctors,
Mhm.
and every doctor that comes on our rotation to learn, these include adult doctors, and medical students going into adult specialties. I ask all of them, so do you have a sleep curriculum in medical school? I mean, so going through medical school, so I'm Canadian trained. And in my medical school teaching, we did not have,
Mhm.
any course on sleep really, unless it was mentioned in the context or in relation to something else, you
Which is
know,
crazy. This
which
is
is
crazy.
it
Yeah.
is, it is,
Yeah.
and in studies that have been done in the States, they have looked at sleep education in medical schools, and they estimate, I think what they found is that, and I'm not quoting this correctly, but in the range of about 2 hours over the entire 4 years of, a medical
Great.
trainees, medical training is devoted to sleep. And guess what? The majority of that time is sleep in adults.
Yep.
Okay,
Yep.
so it is definitely a problem, that stems from, medical school all the way through residency. So in pediatric residency training, because I also, I'm involved in teaching pediatric trainees. There is not a sort of, curriculum or module on sleep in
Yeah.
children. I was in clinic yesterday with a nurse practitioner student who is a pediatric nurse practitioner. There is no sleep training in their curriculum. And so it's a multi-level issue, and not very surprising, unfortunately, that your story is a story that I hear all too often
Mhm.
with, from friends, from patients that walk through the door. And so, I think that it's an issue, but I think it's not an issue that cannot be corrected and cannot be addressed and cannot be remedied. And so, how do we actually go about doing that? I think it's a two-part process. I think we have to educate families so that they can
Mhm.
advocate for their children,
Yep.
because I think advocacy is one of the, like, most powerful, things that we can do for our kids. And so, I think education at level of the parent and education of our doctors, really. And so,
Yep.
in this course that I'm doing, I actually plan to provide, like, educational handouts that, sleep consultants can
Love
provide
that.
to families to
Yeah.
basically, a sort of highlight to them and teach them, what to actually say when they go to their family doctor, and
Yep.
what to ask directly for. Because I think that for most primary care providers, if you go into their office and you say,
Yeah.
here is what is happening, this is
Yep.
what my child needs, can you please refer me? I would say that most, if not all, would go ahead and do what needs to be done, I think.
Yep. My doctor
So
was great. My family doctor listened to me. The
yeah.
big thing, you said this, um, my daughter had taken off her own pull-up at 3, like, on her 3rd birthday. I was like, "I'm never wearing this again." I was like, "Great." And then all of a sudden at 5, she's wetting the bed 4 out of 7 days,
Yeah,
and
that's
which,
a big red flag.
yes,
Yeah.
can be normal, but I also know my kid, and that was not normal for her.
Yeah, yeah. So what we defined as secondary bed, like nighttime bedwetting or secondary nocturnal enuresis, is when a child goes for a total of 6 months without wetting the bed and then starts to wet it again. So, as a child starts to toilet train during the day and overnight, it's normal for them to have accidents here and there.
Mhm.
But if they go 6 months of dry nights every night and then all of a sudden start to wet again, then it definitely is something that, sleep apnea can be one of the causes. There are other causes, but
Mhm.
if you combine snoring with that type of observation, then for sure sleep apnea should be high on the list of possibilities and conditions that you look into.
Mhm.
Yeah,
Absolutely.
yeah,
You've mentioned your course a few times, and we have a
right.
lot of, well, I have my own certification program,
Yes,
so I imagine they're all listening. You're actually coming to do a session
right.
with
I'm so
the
excited.
entire team. Me too.
Yes.
And you also have your own course for sleep consultants. Tell us a
Yeah.
little bit about
So
that.
it's still in the making. So it's a course that I'm hoping will equip a sleep consultant with knowledge about. I mean, I think you guys are really well versed and do an excellent job on sort of behavioral sleep issues.
Mhm.
And so I hope that this course will actually, well, the purpose of it is really to educate sleep consultants about all the non-behavioral slash
Yep.
medical conditions, and not with the intent of a sleep consultant diagnosing a child or trying to treat a medical condition, but more about equipping sleep consultants with the knowledge to know when and what could potentially be
Yeah.
going on in the
Yep.
in the context or in the course of their work with a family. Because
Yep.
I think what I love about sleep consultants is that, first of all, families trust you guys up like so much,
Mhm.
but also that you guys have this opportunity to intimately interact with our family and
Yeah.
to really spend that time and get to know that child. And so
Yeah.
um, the hope is that issues that do come up that may be outside of what the training that you guys have experienced, you'd be able to identify really quickly
Yeah.
and be able to say to the parent, here's what I think is going on, provide a handout potentially to say, this is
Yep.
this is some more information about it, and these are some resources that that you should look into in order to
Yep.
deal with this issue.
Yep.
And so it's a course that I've actually in the process of creating with about 5 sleep consultants to get, because I want to personalize it so that it
Yep.
actually it is tailored to your
Yep.
needs.
Yep.
And so I'm working with 5 sleep consultants to create it. It will have about 6 modules. The first 3 will set sort of a background for what sleep and non-behavioral sleep issues look like. And then the
Mhm.
next 3 modules will actually review cases to sort of walk through an
I love that.
algorithm, yeah, of
Yeah.
how to get to a condition that could be going on, and how to proceed, navigate, I guess,
Yep.
through that. Yeah, yeah,
I also think that especially an experienced sleep consultant, I mean, yes, we get to know the family, but we also know what success looks like. And we know, like, a lot of the factors that are involved in sleep, especially with babies. Like, a lot of it has to do with food and wake windows. Like, unlike a lot of doctors, like, this is all we do. This is all we do. And so
exactly.
we have a good range of what's normal and what's not. And when a child isn't responding, I think the most frustrating part is we really want to help. And
Yes,
sometimes it's that, maybe sleep training isn't right for that child. Yes, that is 100% a possibility. But when there are other factors going on, like you said, like digestive issues, possible allergies, they just need to be ruled out and investigated.
Right.
And I really, when you came along, I'm so excited for you. I feel like there's so much opportunity for you in this because and I mean, I could talk about this for days, but I think it's so, I'm currently doing my degree right now for social
Mhm.
work, and we're
Mhm.
learning all of these therapeutic modalities and how to help folks and how to help
Yeah.
people. And in every single start of every single session, it's like, well, before you start any cognitive behavioral therapy, assess sleep. Do da 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 da, assess sleep. And it is the basic. And if you went
Yes.
to a doctor and said, well, you know what? My child doesn't drink water. Well, we would all be like up in arms. And how do we hydrate the child? Hydrate. It's like the sleep has been an option and in many brains, like optional or a nice to have for really,
Yeah. Yeah.
everyone. And
Yeah.
we really like, even if I'm not involved in this movement, we have to make like it's food, water, sleep.
Yeah. 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 No, it's a foundation. It's like the
Yes.
foundation. The foundation.
Yes.
Yeah. 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 And so, yeah, for sure. I mean, my vision is that, I mean, there will be an education curriculum for pediatric like nurse practitioners, for
Yeah.
pediatric nurses, for
Yeah.
family doctors, for pediatricians, and for
Mhm.
pediatric subspecialties where they're going to see kids that are going to have disrupted sleep,
Yep.
kids with type 1 diabetes, kids with, again, cystic fibrosis,
Yeah.
sickle cell disease, and any chronic like health condition. I mean, there've actually been a few studies in kids with cancer and their sleep. And so
Mm.
my hope is that the sleep education curriculum will be broadcasted to the medical arena,
Yeah.
and that it will be viewed as something that's so key and integral and something
Yeah.
that needs to be assessed and addressed, because asking about sleep is one thing, but if you don't know and you don't have the tools,
Yes. Yeah.
right, to address that,
Yeah.
then what's the point?
Yeah,
Right? Yeah.
100%.
Yeah.
At every wellness check, they ask about sleep. And like, okay, so if I said it's bad, what's your answer? Is it,
What's
yeah,
yours?
well, that's normal. Yeah, well, it
Yeah.
is normal. But
Yeah. Yeah.
also, if it's not, now what?
Right.
Right?
There's a lot of emerging evidence as well that says kids who like have sleep issues, that when they are corrected early, it prevents the development of chronic sleep health
Yeah.
issues and
Yeah.
the outcomes of that. Studies are looking now at sleep health issues in toddlers and how that correlates to mental health conditions
Yes.
in adolescents. And so, I mean, there are just so many reasons why the focus needs to be on sleep.
Yep.
So yeah.
Well, this is, I always joke that this podcast is the length of a crap nap, and I think that we're way over that. So my apologies.
No
But
problem.
where can folks find you? Where can we find more information?
So I have an Instagram page called The Sleep Gap. So it's at The Sleep Gap on Instagram. And I hope that in the next, I mean, my course, I'm hoping to sort of have out with a like an actual formal website in the next couple of
Awesome.
months. So I can
Great.
pass that information along to you when it does become available. But for
Awesome.
now, if you follow me at The Sleep Gap, you'll be in tune and sort of aware of where that will end up going.
And we can look at your adorable boys
Oh,
that
yes.
are just so cute every day.
Nice.
Well, thank you so much for coming.
Thank
I
you.
mean, I am out of words, but if, as always, you are struggling with the behavior of your sleep, you can find us at babiesbestsleep.com or on Instagram at babiesbestsleep. Don't forget to subscribe and leave a review, especially if you like this episode. I mean, this is free advice, folks. So go ahead and say thank you through that review and a rating. Have a good one. Bye.
Bye.